Okay, good morning. We'll be continuing with the oral medicine part that we have left last class. Okay. So total RBC count is. Anybody wants to try? Yes. Okay. Be careful of the millimeter cube and centimeter cube. All right. Conversion of centigrade to Fahrenheit is. So what is the normal human body temperature? 37 degrees Celsius. So what is the Fahrenheit counterpart? 98.4 degree Fahrenheit. Okay. So how do they do the conversion between centigrade and Fahrenheit? You want to try? Yes. B. Okay. So be very careful of the into plus minus. One thing changes, the entire thing changes. You can actually try doing conversion. 37 is taken as a standard. You could probably try for 38 degrees, for 39 degrees. They can ask you to do the conversions. Okay? Normal serum calcium level is A. Be careful of grams and milligrams. Okay? It is only milligram per dl. Some textbooks give it as 9 to 11 milligrams per dl. Okay? This is the actual value. They have given it in a rounded off value. Normal inorganic phosphorus level is calcium and phosphorus are inversely related. When the calcium level in the body goes up, the phosphorus level comes down. Alright? So the normal inorganic phosphorus level can be A. Okay. Yeah. Normal serum alkaline phosphatase level. Where do you find an elevated alkaline phosphatase level? Pages. Okay. So normal serum alkaline phosphatase is. What is IU? International units. So B. C. 30 to 110 international units. Normal fasting blood sugar level FBS 70 to 100. It is again milligram per dl. Normal HbA1. What is HbA1? Glycosylated hemoglobin. Under that you have HbA1A, B, C. 3 varieties. Alright. This value I am asking is a total of A plus B plus C. So what is the normal glycosylated hemoglobin level? So this is considered as a more appropriate finding of your glucose level rather than your RBS, FBS and PP. Why so? Because this is a constant. This will not change with time. Okay. So anywhere it goes above or below this normal level, you consider the patient as be a positive definitive diabetic. Your FBS, your RBS tends to change with time. Normal serum glutamic oxaloacetate transaminase. Where do you test for SGOT? For which condition? Liver disease. Any liver disease you can go for SGOT. So the normal level of SGOT is it's per liter, not per ml. And 25 units per liter is for SGPT, pyruvate transaminase. Sorry? Yes, per liter. 25 units per liter is for SGPT, 8 to 50 units per liter is for SGOT. These both are units for measurements for liver disease. Any value going beyond this, you can say patient is likely to have a liver disease. Normal prothrombin times. Okay. What is normal bleeding time? Normal bleeding time? Be very safe, give a range, okay? Keep it as 2 to 4 minutes. Normal clotting time? Okay. Normal lactate dehydrogenase level. Whatever normal level you are reading, read it only from Burkitt's. Whatever level, it will be given like a tabular column in the 8th edition. 8th edition Burkitt's, you will be having a tabular column of normal values. You have a chapter on investigations. If I am not wrong, it's the 8th chapter, 8th or the 9th chapter. So that chapter is exclusively only on investigations. Read the normal values only from that. 8th edition of Burkitt's. Normal lactate dehydrogenase level, where does your LDH increase? Again, liver disease, you will have lactate dehydrogenase increase. You have various subtypes like LDH 1, 2, 3, 4, 5. So each thing signifies 1. And LDH 5 signifies myocardial infarction, LDH 2 signifies liver disease. Alright? So normal lactate dehydrogenase level C. Again, it is per liter. Most of your liver findings, your normal values will be per liter. Normal blood urea nitrogen. What is blood urea nitrogen? Yeah, so how does it form? Normally, you have muscle breakdown, tissue breakdown, alright, protein breakdown. You will have urea excreted into the blood, and that has to excrete in the urine. And the capacity of this excretion is lost in case of your renal disease. When that is lost, urea is not excreted in the urine, but is retained in your blood. That is why it is called as blood urea nitrogen. Okay. So the normal blood urea nitrogen level is when it goes beyond 100 to 200 milligram per dl, it is considered as a definitive renal failure. Normal 24-hour excretion of protein in urine. 24-hour excretion of urine sample should be up to 1200 to 1500 ml of urine. That is a normal urine excretion volume. Alright, so that how much of protein should be present. What are the types of proteins you know? So, normal proteins. Weinstein protein is a pathological protein expressed during multiple myeloma. Alright? So, normal protein excretion in a 24-hour urine sample is beyond it goes, it's called as proteinuria or albuminuria. So, the normal level is 50 milligrams. Normal specific gravity of urine. A? Okay. Sorry. Yeah, the answer is A. Alright. So, if it is more than that, it is called as hyperesthenuria. If it goes less than this, if the specific gravity is less than the normal, it is hypoesthenuria. When it happens, when there is lot of fluid accumulation, it gets diluted. Then your specific gravity will go down. Alright? When there is dehydration rather than fluid accumulation, then your specific gravity will go high. What is the formula to measure child dose using Young's rule? D? Okay. What is A? Clark's rule. Okay. Normal lifetime of RBC? 120 days. The other is for platelet and the last is for coumarin. What is coumarin? Vitamin? Anticoagulant. Warfarin, coumarin, anticoagulants. Normal INR is, why do we do an INR? Prothrombin time varies with time in the blood. It keeps varying every minute and every hour. So to standardize the prothrombin, they brought about an INR, which is given as prothrombin test by prothrombin normal whole of ISI. ISI is your international units. This formula is used to calculate INR. So the normal value of INR is 1. It goes to 2 in case of, when does the INR increase to 2? When patients are under anticoagulants, aspirins. When does it go to 3? When patient is having atrial fibrillation. When does it go to 4? When patients are on prosthetic heart valves. Okay? So 2, patient is on anticoagulants. 3, patient is having atrial fibrillation. 4 is when patient is on prosthetic heart valves. All this will be given in your Burkitt's 8th edition. So these are some of the normal values you must know. Investigations, okay. The following are methods of estimating the bleeding time. A and B. Where do you do IV method? On the forearm. And Duke's method is what you do a pinprick. Leavitt's method is method of, no? What you do in lab is Wright's capillary tube method. The other method is Leavitt's method. Wright's capillary tube method you do it for clotting time. Okay? Leavitt's method is also for clotting time, where they will collect 1 ml of blood sample in series of test tubes of 4 and place it in a water bath and wait for the clotting to happen. Test for scurvy. Which blood test will you? All of the above. The other name for Rumpel test is tourniquet test, and these are tests for capillary fragility. Vitamin C deficiencies, patients will have capillary fragility. So basically the answer is all of the above. How do they do Rumpel test? Tie a tourniquet, okay, and they will mark a 2 by 2 centimeter square proximal to the antecubital fossa. It will be marked here, and they will look for petechiae on the box. So more than 10 to 20 petechiae is considered as positive for capillary fragility. Tests used to measure intrinsic system of factors. You have clotting factors 13. Half is intrinsic, your half is extrinsic, and then you have factors common to both intrinsic and extrinsic. Okay? Prothrombin time is for your extrinsic system of factors. Duration of action of heparin. Right? Transport? Coumarin. It's a longer acting anticoagulant. Paul-Bunel test. It's a titer of heterophil antibody. Infectious mononucleosis? Yes. Tuberculosis can be diagnosed by all of the above? Alright. The gold standard tests for all stages of HIV is, even in the primary stage, even in the initial exposure stage, you can find PCR. Even if one virus is there in blood, it can be identified by PCR. But otherwise, all the tests are tests for HIV. All the remaining tests are tests for HIV, but PCR is your gold standard. Kevin test is used for the diagnosis of sarcoidosis. Alright? You will take an infected lymph node aspirate and give it in the subepidermal skin of a non-infected or suspected infection patient, and that you will observe the patient for 48 hours to 72 hours. If there is an induration seen on the skin of that patient, then the patient is considered to be positive for sarcoidosis. Zank smear test involves the use of following stains except. Where do you do Zank smear test? Herpes and pemphigus. Alright? So where do you, which are stains you use for the Zank smear test? How is the Zank smear? Gram stain. Alright? So you take a fresh vesicle, it should not have ruptured, and you break the vesicle and take the scrapings from the base of the vesicle, spread it over a slide, heat treat the slide, and then give a Jameson stain, Pap stain, dry stain, and then observe it under microscope. This will be the test for Zank smear test. Test for syphilis is all of the above. The lowest concentration of a drug at which there is no visible growth in antibiotic sensitivity test. This is called as the lowest concentration of a drug at which there is no visible growth. B is you will do the subcultures from those test tubes, and the subculture where it shows no no microbial growth at all. That is your minimum inhibitory concentration. What is minimum bacteriostatic concentration? There is no such thing. The following may be causes of paresthesia of inferior alveolar nerve. Which of the following? Okay. Anything else? Anything else? No? In sickle cell anemia, you will have sickling phenomenon. Those RBCs will stick or adhere to your blood vessels. When that happens, you will have paresthesia of your inferior alveolar nerve. Osteomyelitis, you know why, because of your sequestrum and involucrum formation, and there is your lifting up of your periosteum, you have inferior alveolar nerve paresthesia. Multiple myeloma, it's because of the plasmablastic tumor, okay, and your neoplasm of your plasma cells. That itself will cause a inferior alveolar nerve paresthesia. Answer is all of the above. Apart from this, anything else? Paresthesia of inferior alveolar nerve, trauma and improper injection technique, neoplasms of your inferior alveolar nerve canal, all this can cause paresthesia. What is strabismus? C. Crossing of eyes. What is drooping of eyes? Okay. Watering of eyes? Watering of eyes? It doesn't have a meaning. Okay. What is increase in the intercanthal distance is called as? Taylorism? Little of the syndromes now. Fibrous dysplasia, capillary spots and endocrine disturbances are features of B. Okay. It is not A because in A you will not have endocrine syndromes. You will not have any of the endocrine disturbances. What is Gardner syndrome? Multiple impacted teeth, supernumerary teeth, multiple cysts, intestinal polyposis, all comes under Gardner syndrome. Syndrome with the trial of oral lichen planus, diabetes mellitus and hypertension. Greenspan. Plummer-Vinson syndrome, iron deficiency anemia. Sika syndrome, Jabran syndrome without the autoimmune disease. Vulvovagino-gingival syndrome, that comes along with lichen planus. Lichen planus along with lesions in the vagina, vulva and the gingiva. It's one of the syndromes affecting along with the lichen planus. Lichen planus can be associated syndromes along with Greenspan syndrome. Acrobrachycephaly, Klebstachell's deformity, propoptosis, hypoplastic maxilla, syndactyly are features of your tower-shaped skull, clover leaf-shaped skull, propoptosis of the eyes, hypoplastic maxilla, syndactyly clubbing here. B. Okay. What is Clausen syndrome? Without syndactyly. Lobster claw syndrome. The patients will have missing digits and the remaining digits will be fused together. Okay. And patients will have hypoplastic maxilla again. but they will not have acrobrachycephaly and Kegel's deformity. Ashker syndrome, double lip. Basal cell carcinoma, multiple KCOT, vertebral anomalies are features of bifid rib syndrome. Achondroplasia is seen in, what are the features? Short stature, frontal bossing, mid-face deficiencies, brachycephalic skull, Beckwith-Wiedemann syndrome, macroglossia syndrome. Okay. Costin syndrome, ear deformities, and it is related to any kind of TMJ dearrangement. Raynaud's phenomenon, sclerodactyly, telangiectasia, some features of crest. So what does C stand for? Calcinosis cutis. Raynaud's phenomenon, esophageal strictures, syndactyly and telangiectasia. Right. Cowden syndrome is multiple neoplasms, adenomas, benign swellings, and you will also have cobblestone appearance, which I already told you last class. In cobblestoning of your intestine and oral mucosa, that is seen in one other lesion other than Cowden syndrome, which was done last class. Some GI disorder, Crohn's disease, oculocutaneous albinism, AC bruisability, ulcerations, recurrent infection with neutropenia are features of Shediac-Higashi syndrome. Sturge-Weber syndrome is hemangiomas, tram-like, pipe-like calcifications will be present, phlegoliths will be present. Maffosi syndrome is a features, lymphangiomas, hemangiomas. Gardner syndrome I have already told. What is oculocutaneous albinism? The skin and the eyes will have albinism features. Depigmentation will be present. Alright. What is the special feature of a neutropenic ulcer? It was done last class. It was done last class. The ulcers of neutropenia are different from normal aphthous ulcers. It has one characteristic feature. The halo will be white in color. There is no signs of inflammation, so you will not have a erythematous halo. Unerupted teeth, dentigerous cyst, hypermobility of shoulders, brachycephalic skull, short stature are features of cleidocranial dysplasia. Cleido means clavicle. Cranial, you have a brachycephalic skull. Dysplasia is you have the other features. Down syndrome, it's your 21 trisomy syndrome. Alright. Eagle syndrome, elongation of styloid process. There's a difference between Eagle syndrome and stylohyoid syndrome. Eagle syndrome, you will have elongation of styloid process, but in Eagle syndrome there will be pain on turning the neck. But and there will be a neck injury. Whereas in case of your stylohyoid syndrome, you will not have neck injury and there will not be any pain on turning of neck. PFA-PA syndrome, it's a syndrome associated with your aphthous ulcers. Periodic fever, adenitis, pharyngitis and aphasia. Periodic fever, adenitis, pharyngitis and aphasia. Fissure tongue, cheilitis granulomatosa, Bell's palsy are features of Ramsay-Hunt syndrome is vesicles, your herpes zoster vesicles unilaterally present, and they'll have some ear deformities also, ringing sound there. Patterson-Kelly syndrome, other name for Plummer-Wilson syndrome. Papillon-Lefevre syndrome, of the palm and soles, and there will be aggressive periodontitis and premature of teeth. Multiple impacted tooth is seen in A and B, and in C you will have missing teeth. These are your basic syndromes that you must know. We are moving to the drugs part, and the drugs commonly used in oral medicine alone. Alright? Which of the following drugs is anti-herpes virus drugs? Oh, it is except. Alright, stavudine is not an anti-herpes virus. It is except. The question is except. And edoxuridine it is given for refractory cases. Patients who are not responding properly, they give edoxuridine. The question should be, which of the following drugs is anti-herpes virus drugs except? The following drugs are antifungal polyenes except. Alright? Which of the following drug binds with sterol moiety of the fungal cell membrane leading to leakage of essential components? This is not a general antifungal mechanism. The other mechanism is your P450 chromosome is being affected. So that is the other mechanism. Only one of the drugs is having this mechanism, and that is amphotericin B. The others, the mechanism falls as it will affect the P450 chromosome, cause a drug interaction between the cell and the antifungal, and that is how the drug acts. Ketoconazole is available as, there is a lot of confusion between gel, ointment, cream. Be very careful before answering. So ketoconazole, Indian availability. You know the answer, don't even read the other options. It will only confuse you. Opioid antagonists are D. Alright. What is pentazocine? Pentazocine and buprenorphine are mixed agonist-antagonist action. Which of the following drug increases sedation during alcohol consumption due to drug interaction? Opioids. What is the side effect with ibuprofen? Brown spots? Okay. Then gastritis. So you are not going to prescribe Brufen for asthmatic patients. The effect of celecoxib, what is the side effect? You do not prescribe it for cardiac patients. Which of the following are purine antagonists? These are your chemotherapeutic drugs. So which of the following are purine antagonists? C. That is a pyrimidine antagonist. 5-fluorouracil is a pyrimidine antagonist. The common drug used to treat lichen planus? Triamcinolone acetonide. It's commonly available as Kenocort. What is capsaicin? That was done last class. It's a substance P depleter. It is an extract of chili peppers. The following are antifungal agents except ornidazole. Everything becomes an azole, so that's again in confusion. And there's one more drug called clotrimoxazole. So be very, yes, it's an antibiotic. It's not an antifungal. It's a combination of sulfamethoxazole and trimethoprim. So you should not be very careful of clotrimazole and clotrimoxazole. The cytoprotective adjuvant used in cancer chemotherapy and radiotherapy. Amifostine. So this will be given 30 to 60 minutes before giving radiotherapy or chemotherapy. so that you are trying to protect the normal cells. The rule of 2 applies for. There are 2 rules which I remember for oral medicine, rule of 10 and rule of 2. Rule of 2 applies for steroids. So any patient taking more than 20 milligrams of steroids for more than 2 weeks, in any time who are reporting to you in less than 2 years of time, then you must double the dose of steroids when you are doing the treatment. I tell you again, a patient taking more than 20 milligrams of steroids per day for a period of more than 2 weeks, in any time less than 2 years during his time of reporting to you as a dentist, then you double the dose of steroids administration so as to avoid HPA axis suppression. What is HPA axis? Hypothalamus, pituitary, adrenal. This crisis should not occur, so to stabilize your HPA axis, you are doing a doubling dose. What is rule of 10? To perform cleft lip surgery. So 10 grams of hemoglobin, 10 lbs weight of the patient, 10 weeks old baby. The drug used in anaphylaxis is what? A. All of the above. Epinephrine is antihistamine. Diphenhydramine is, sorry, what is epinephrine? Adrenaline. Okay, yeah. And that is for your vasoconstriction. Then your diphenhydramine is your antihistamine. Then you give steroids, which is anti-inflammatory. So together, these are the proper doses. So you can go through the doses. Together, you will give for anaphylaxis. That was the end of your oral medicine part. X-rays were discovered by Röntgen. Okay. W.A. Price gave the bisecting angle technique in 1904. H.R. Raper gave the bite-wing technique. Coolidge tube was given by W.C. Coolidge in 1913. Quantum mechanical model was proposed by C. Ernst Mach gave what? What did he give? Mach band effect. That was given by Ernst Mach. What is Mach band effect? Mach band effect? It's an optical illusion. When the light areas meet another dark area, then the light area appears lighter and the dark area appears darker. It's an optical illusion topic. Concept of ALARA was given by, what's the abbreviation of ALARA? As low as reasonably as achievable. So that was given by A. A is OPG. Umeta and Patiro gave OPG. Paul C. Lauterbur gave MRI. And Godfrey Hounsfield gave CT. So your answer is Preece. Mass of a proton is A. It's gram, not milligrams. It's already minus 24, so we'll keep it as grams. The amount of energy required to remove an electron from a given shell must exceed the electrostatic force of attraction between it and the nucleus. This is called as ionization energy. A. It's both A and B, the other names. Alright? What is kinetic energy? Any moving object is said to have a kinetic energy. So that is a concept where when the electrons are flowing from the cathode to the anode, you have the kinetic energy of the electron is being converted into the energy of photons. The rate of loss of energy from a particle as it moves along the track through matter, which is a tissue, is called as linear energy transfer. Quantum theory considers electromagnetic radiation as small bundles of energy called as, what is positron? It's a subatomic particle of proton. The unit of photon energy is called as, no doubts? The properties of tungstens are all of the following except high boiling point. The size of an actual focal spot is 1 into 3. The size of an effective focal spot is 1 into 1 mm. So what principle does it work on? Your actual focal spot and effective focal spot works on the principle of, there is a principle for that name. Sorry? It is called as line focus principle. You are trying to focus the incoming beam into a point at the focal spot, and when you are trying, what you are doing effective focal spot is not possible to do it. It's a theoretical concept, but practically you can make an actual line focus principle. You are trying to dissipate the heat. That is why you are trying to angulate your anode. 74. Atomic number of tungsten is 74. Power of safe lighting in a dark room is 15 watts, and it can go up to 25 watts. The distance between the safe light and the work surface is 6 feet. B, 4 feet. It is also 1.2 m. Answer is A and B. It's 1.2 m meters is equal to 4 feet. Alright. Size of the master tank is both A and B. That is in inch, this is in centimeters. The key ingredient of a developer solution is both A and B? Yeah. So, what is the acidifier or what is the activator? Sorry, what's the activator in developer solution? Sodium bicarbonate, alright, and that is an alkaline solution. Developer is basically an alkaline solution and fixer is an acidic solution. And the preservative is sodium sulfite. Why do you need a preservative? What is the logic behind the preservative? You are placing the solution outside. So, with the interaction with your air molecules, it can get oxidized. So, to prevent the oxidation of developer, you have a preservative. And then there is a restrainer, potassium bromide and benzotriazole. What is the function of a restrainer? It restrains the undeveloped crystals. Okay, unexposed crystals, it will restrain the unexposed crystals. Restrain the development of the film of unexposed crystals. Key ingredient of fixer? A. So what is acetic acid? Activator. Let's see acidifier or the activator part of it. Ammonium sulfite is your preservative, same reason as your developer, and hardener is ammonium sulfate. Why do you need a hardener for fixer? On developing, your gelatin swells up, it becomes soft. So to harden that after the film processing is over, if it is not hardened, then while maintaining, your film will get bent and you will have a lot of marks. So to prevent that, they are adding a hardener which is your aluminium sulfate. So what happens when you are first developing the solution is, you open the film, dip it into the developer, your silver halide crystals will be exposed to the developer, causing the conversion and formation of a black metallic silver. You have a latent image formation, and when you are exposing this to your fixer, between these two you should have a wash step. Why do you have the wash step? Is to remove the excessive developer and to prevent the neutralization between the alkali of the developer and acidity of your fixer. So you wash the film and then go into the fixer. To go to the fixer, you are creating a visible image and you are removing all the unexposed and undeveloped crystals. You are removing it through the fixer, and then you are hardening with the aluminium sulfate to make it as a useful film. The developer replenishment can be done by adding 8 ounces per gallon, 1 gallon is equal to 3.8 liters. So the answer is A and B. Alright? Answer is not written. Answer is A and B. 1 gallon is equal to 3.8 liters. And how much of developer replenisher will you add for an automatic processing? Automatic processing, it is 6 ounces per gallon. And your fixer is 3 ounces. Developer is 6 and fixer is 3. What I am telling is for automatic processing. Diameter of collimator is A and B. Be very careful, slow, no hurry. So, what is the function of a collimator? It collimates the beam. It reduces the diameter of the incoming X-ray beam. It does this so that there is not much of exposure to the patient. You are reducing the exposure to the patient. Material of a Coolidge tube is borosilicate glass tube. Dimensions of tungsten coil is take, time and tell. A. Alright. The unit of absorbed dose is, sorry, B. No, I didn't get the answer. C. D. You must know about the exposure, absorbed dose, equivalent dose, effective dose and radioactivity. The last one is your radioactivity, the first one is your exposure, the third one is your exposure dose. Yeah. Alright. So what is GY? Gray. RAD is rad. SV is sievert. BQ is becquerel. CI is Curie, named after Marie Curie and Pierre Curie. Maximum accumulated dose is measured by, what is maximum accumulated dose? The amount of radiation that is being taken up by the radiation personnel. Who is your radiation technician? So how much of radiation that is taken? They are using those badges. So how do they calculate that? Maximum accumulated dose. There are two things, maximum accumulated dose and maximum permissible dose. Maximum accumulated dose is something that is happening over a period of time, say 1 month or 1 year. But maximum permissible dose is a dose that is allowed for that personnel during his lifetime. If it exceeds if that dose, say suppose it is 5 rem per year and it goes up to 50 rem per year, he has to quit his job. So that is your maximum permissible dose. It's a dose beyond which you are not allowed to work as a radiation personnel. So the formula is, no idea? N minus 18 into 5 m per year. N is a value where you will, what you have measured from the badge. That will be N. You are calculating using this formula to find out the normal value. The exposure of a full mouth IOPA is, this will be more than your OPG. This value is more than what you are doing in OPG, full mouth IOPA. 0.31 sievert. The others are all false values. It doesn't come for anything. For a machine of more than 70 kVp, the aluminium filtration required is 2.5. 1.5 is for a machine which is less than 70 kVp. A machine less than 70 kVp, you give an aluminium filtration of 1.5 mm, and for more than 70 kVp, you give an aluminium filtration of 2.5 mm. The following are inherent filtration techniques. What is filtration? Filtration is something which will absorb your scattered radiation. It will prevent film fall. And the common material, your external filtration is aluminium. So what filtration you use for a machine is internal filtration plus external filtration is your total filtration for that particular machine. I already spoke about the external filtration of aluminium. Now you have to tell me which are all the techniques for internal filtration, which means which is already inbuilt in your Polish tube. All of the above. The thickness of an absorber such as aluminium required to reduce by 1/2 of the number of X-ray photons passing through it is called as half-value layer. That's a definition for half-value layer. Decreasing the KVP will, what will it do? What is KVP? Kilo voltage peak. What are the three factors which are controlling the X-ray beam? Milliamperes, kilo voltage peak and seconds. So these three are the factors which are controlling the X-ray beam. So when you're it is definitely A, alright. When you are decreasing the KVP, it will improve your contrast. But obviously it is not B, it will not decrease the contrast. It will happen when you are increasing the KVP. So ideally you must keep KVP at a low level. And number of electrons and is for MA. KVP is velocity of electrons, not number of electrons. Number of electrons is MA. So with that you can rule out the last two options. Product of KVP, MA and seconds is called as the product of KVP, MA and seconds is called as heat storage capacity. Heat storage capacity. What is tube rating? The rate at which successive exposures can be made is called as duty cycle. Tube rating is the rate at which you can give that much of heat to it, but it does not melt your target. Okay, the amount of power that you can give to the cathode that does not melt your target is your tube rating. Heat storage capacity, the one which I told you just now, for anodes of dental diagnostic tubes is, this you have for OPG separate, for IOPA machine it is separate. HU stands for heat units, not Hounsfield units, it is heat units. Yep. So the heat storage capacity for anodes of dental diagnostic tubes is, any idea? No? 20 kilo heat units. All this is there in your white and ferro. The other names for coherent scattering. All of the above? Okay. So what are the two types of reactions that occur at tungsten when an X-ray is formed? It's called as Bremsstrahlung radiation and characteristic radiation. These two are the interactions that is happening at the tungsten level when the exposure is going to be made. Alright? And what are the interactions of the X-ray particles on matter? The three interactions of Compton scattering, coherent scattering, photoelectric absorption. These are the three interactions that is happening from the X-ray photons when it interacts with matter. Apart from this, you have a fourth interaction which is no interaction. It just goes in and goes out. Alright? One type of interaction is there is no interaction between the X-ray particles and your tissue. The following are properties of X-rays except. The following are properties of X-rays except. It can be reflected. That is the wrong answer. D. Just now I told you about three interactions and you are telling me D. Can be reflected. Okay. It has no mass, no weight or no charge and it is invisible. Right. The test used to evaluate safe lighting is? Yes? A and C. That's the other names. Some textbooks give it as coin test, some textbooks give it as penny test. What is reference film test? What is it done for? To check your solutions, whether it is of a proper concentration. If If you want to change the solution, that can be estimated using a reference film test. And you have your step wedge technique, which is done using your lead foil. You club all your lead foils, 5 lead foils together and cut at 1/4, 2/4, 3/4 and 4/4, and you will keep an X-ray film on top of the wedge and shoot the X-ray. You will get an X-ray film of varying densities. You compare the daily films with the step wedge film and see for the contrast. If it is going to be very black, it means your solution is black, I mean it is too strong. If it is going to be white, which means your solution is depleted. Okay? This is to check the concentration of your developing solutions. You are checking the contrast. You are checking the contrast of your daily films and the reference film. The reference film can be freshly developed, freshly made solutions that you can take as a reference film, or you can make a step wedge technique out of lead foils. There are 2 techniques to make a reference film. When you are taking a reference film, it should be from a new box of IUPA films. Your X-ray machine should be calibrated. Your developer and fixer solution should be freshly made, and then you develop a X-ray and keep it aside. So that will be your reference film. This is one technique. The second technique is a step wedge film. Okay. The frequency with which successive exposures can be made without damage to the tube and depends on the tube build-up. This is called as duty cycle. Okay. What is inverse square law? The intensity of the incident beam is equal to the square of the distance between the source. The intensity of the X-ray beam at a given point inversely as a square of the distance of that the point from the source of radiation is called as inverse square law. What is Bernoulli law or Terbondi law? Something in radiation biology. This is there in your 6th edition White and Farrow. What your reading was 5th edition, right? Your batch had 5th edition White and Farrow. This is there in the 6th edition White and Farrow. This law is nothing but it determines the radio sensitivity of your cells. You have, right, the high sensitive cells, the medium sensitive cells and the low sensitive cells. That is determined by your Bernoulli laws. The size of a periapical size 2 film is C. What is 22 by 35? Video film. And 24 by 40? Size 1. There is no size of 23 by 30 mm. Size of occlusal film is 57 by 76 mm. 31 and 41 is already discussed. 24, 40 is already discussed. 27 by 54 is for bitwins. The thickness of a polyester polyethylene terephthalate base is. Your IOPA film is composed of your crystals, silver halide crystals and a base. And you have a gelatinous base. Alright? You have a carrying medium. Your silver halide crystals, you have silver iodide, silver bromide, grains of silver and some impurities such as sulfur to block the remaining portions. Big crystals, and then you have small spaces. Those small spaces having small crystals, and between the big crystals and the small crystals you have tiny spaces that is filled by impurities. On the whole it will be a packed crystal. Okay, this is your crystal lattice structure. Apart from this, your gelatinous base and your crystals will be loaded onto a base, and that base is your polyester polyethylene terephthalate. So the thickness of that base is 0.18 mm. The device which is used to move a grid is called as Bucky. The other name is Potter-Bucky diaphragm, so the answer is D. You have 2 names for it. What is a grid? You will have a primary beam and you will have a secondary beam. The primary beam is allowed to pass through the radiolucent spacer of your grid, and the secondary beam, which is not in line with that of the patient and your source, that is being absorbed by your lead. Alright? And the thickness of your the thickness and the width of your radio opaque grid portion is given by the grid ratio, and the grid ratio is D. I didn't know. It was 8:10. It's your textbook answer. It is given by H by D. That is a formula. Height by diameter. The differences in the various gradations of density in the different areas of a radiograph is called as you must know these radiographic density, contrast, speed, film latitude, film noise. All these have definitions. Contrast, yes. So the overall degree of darkening of a radiograph is called as density. Okay, and the rate at which you can take a radiograph is your radiographic speed. And film latitude is the varying densities that can be recorded as a clear-cut difference of densities. The reflecting layer of an intensifying screen is made up of, what are the parts of an intensifying screen? You have a front cassette, you have a back cassette. The front portion is your metal, no, the front portion is a plastic, back portion is a metal, and then you have the film inside here. So that may has various layers. One is your phosphor layer on both the sides, and then you have a reflecting layer only on the back side, and that is made up of titanium dioxide. Okay. Calcium tungstate intensifying screen emits blue light. Apart from this, you have, what other light you have? Green light. That is because of the rare earth elements. The position distance rule is that a dentist must stand at a distance of dash from the machine and at an angle of dash degree to the primary beam. See? 6 feet, it's not 6 meters, 6 feet distance and 90 to 135 degrees. The rule of isometry is applicable for, see, what is the other name for bisecting angle technique? Short cone technique. What is the abbreviation for slog? Opposite side buckle. Okay. What is the rule of isometry? It's fully called as Szczeciński's rule of isometry. There are two triangles which has two equal angles and share a common hypotenuse. The vertical angulation for maxillary canines is B? Okay. That is for lateral incisor. 40, 45, 50. The horizontal angulation and bisecting angle technique of molar is D. Any other answer? The horizontal angulation and bisecting angle technique for molar is the horizontal angulation for all the teeth is only 0. Molar is just to confuse you. So what will happen if the horizontal angulation goes wrong? Overlap. The long source to skin distance is, you have long source to skin distance and you have a short source to skin distance. How you place the PID to the patient film, patient skin. B, D, yeah, A and B. 41 centimeters is also 16 inch. The short cone is a 20 centimeter is also 8 inch. The distance between your PID and the skin surface. For your long cone technique, it is 41 centimeter or 16 inch. And for your short cone technique, it is 8 inch or your 20 centimeter. The technique of object localization. All of the above. What is Clark's rule? Other name for slot technique. The radiograph that is best to view both buccal and lingual expansion is occlusal. Okay. What is bite wing used for? Look at the proximal surface. The technique of taking an IOPA and occlusal film is called as the radiographic projection showing oblique lateral views of right and left sides of the jaw on different halves of the same radiograph. They will have, say suppose there is an OPG cassette, okay. They will block one half with a lead plate. They will shoot one side of your TNJ, and then they will block the other half of your OPG cassette and shoot the other side of the TNJ. So both the sides are there on the same radiograph. That is a question. So that technique is called as bimolar technique. Alright. The modification of submentovertex view is called as jug handle view. The technique and parameters are the same except for the fact that, what is the one difference between your submentovertex and jug handle view? D. Exposure factors are decreased by 1/3, which is that used of your submentovertex view. What is the contraindication for a submentovertex view? Any neck injury, you are contraindicating submentovertex view because of the positioning technique. You have a hyperextension of the neck. So submentovertex view is contraindicated for neck injury patients. XCP of a film holder indicates. What is the abbreviation for XCP? You have RIN XCP holders, you have RIN BAI holders, you have ease grip holders. B, yeah, extension, cone, paralleling technique. BAI is bisecting angle technique. The other names for paralleling angle technique are, this is easy, A and B. Okay. The inverted Y line landmark represents. You know which of it is, but this is your A, floor of the nasal cavity and anterior wall of the maxillary sinus. D, first one is correct. A. You know the answer, just see where the answer is, that's it. Excessive angulation IOPA leads to foreshortening. Okay. When does elongation happens? Reduced angulation. Overlapping? Improper horizontal angulation. Cone cut? One is positioning. That is improper orientation of your PID and the film. Second, one more reason. When you are dipping the IOPA film inside your master tank, but it is going only half. So which means only half will be developed and the remaining half will be fresh. So that is also a cause of cone cut. The reversal of film during exposure leads to A and B. Tire track appearance and herringbone pattern are same. What is phalangioma? Impression of your tongue, your fingers. Yeah. The improper horizontal angulation can cause overlapping. What is double imaging? You are doing exposure twice. You click once and then leave, it's fine, but you click once and then click again, then it becomes a double image. The following restorations appear radio opaque except acrylic crown. Radiation injury to organisms result from killing of large number of cells is called as. Really? Really? Is deterministic effects. Sublethal damage to the tissues leading cancer formation is your stochastic effects. The most radiosensitive organ is, Hill's effect is your, when the radiation is going to your target and it is hitting at the heel of your target and there is a heat distribution occurring there, that is a Hill's effect. The most radiosensitive organ is A. Anything else? You want to try? C? Okay. It's only A. The most radiosensitive site in a cell. Parts of a cell, think of your cell, cytoplasm, nucleus, DNA. Okay. In acute radiation syndrome, GI symptoms are produced at 7 to 15. 1 to 2, what do you have? Oral symptoms. Okay. And 2 to 4 and 4 to 7 you have? Early hematopoietic effects and late hematopoietic effects. 7 to 15 you have GI symptoms. And then you develop CA after that. Okay. Up to 50 you will develop CA. The least radiosensitive organ is muscle cells. Adavada kammi? C. Optic lens. Muscle is also correct, but even lesser than that is optic cells. The dose that has a risk of developing bone marrow cancer is, I have given you the answer. It is D because first one is cataract, second is thyroid, 0.5 gray is for salivary gland cancer and 0.05 gray is for your bone marrow cancer. Any of these four can be a question. The amount of radiation a population required to produce in next generation as many additional mutations as arise spontaneously. This is like Hiroshima Nagasaki bomb blast happened. So that is the concept what they are talking about. So some kind of a radiation damage that you are causing to this generation, how much of that damage is required to produce effects even in the next generation. That is a doubling dose. Okay. All the others are dosimetry. The most radiosensitive cells are the ones which undergo many future mitosis, have high mitotic rate and are in primitive stage of differentiation. This is called as. This is what I told you in a few slides before. Bergoni law or Tribondi law. The both means the same. Bragg's law is nothing. The radiograph contraindicated in patients with suspected neck injury. SMV. What is transcranial view? It comes under TNJ view. The radiograph indicated for a pyramidal fracture. What is pyramidal fracture? It's the other name for Leafoot 2 fracture. So your Leafoot 1 is your dentoalveolar fracture, Leafoot 2 is pyramidal fracture and Leafoot 3 is high pyramidal fracture. D. Right. Where do you use submentovertex view? What is the indication for submentovertex view? No. Base of skull. Zygomatic arch fracture is only jug handle view. If you see a jug handle view, you will see only the zygomas. The entire base of skull will be radio opaque. Jug handle view. That is the previous question. You reduce the exposure to 1/3 of your submentovertex view, you develop a jug handle view. In jug handle view, you will see a radio opaque skull. Nothing will be visible. Base of skull will not be visible, but only the zygomas will be visible. So it is indicated for zygoma fracture. The soft tissue profile in lateral cephalometry, it is because of, why does it occur? One of the part of this cephalometric mission is the cause why you have a soft tissue profile in a lateral ceph. D. What are the parts of your lateral ceph machine? Okay. Okay. Chin rest. Do you have a chin rest in lateral ceph machine? No. You have your ear rods, you have your orbital pointer, you have a filter here, and what filter is that? Lead filter? It's an aluminium wedge filter. Okay? So when you see a lateral ceph, have you seen a soft tissue profile outside, which you can never see in any radiograph? That happens because of the aluminium wedge filter which you have placed at the bridge of the nose, that will selectively absorb the X-ray beam and it will give an outline for the soft tissue. And in lateral ceph, you are supposed to ask the patient to be in normal occlusion with the lips closed. If the lips are not competent, your soft tissue profile will not appear. Okay? Thermoluminescent dosimeter is composed of. What is thermoluminescent dosimeter? What are the devices which are used to estimate how much of exposure that has happened to a radiation personnel? Film batches, yes. Apart from that, this is the latest technology which is called as thermoluminescent dosimeter. You will have thermoluminescent batches which is then given in a dosimeter for reading. Okay. The composition is A, all of the above. This is the composition for thermoluminescent dosimeter. The ghost images of OPG are resembles the real counterpart, found on the opposite side of the film, appears larger, indistinct, higher than its actual part. See, it is all of the above. Obviously, a ghost image will look exactly like how it is. Say suppose you have a earring, you will see a earring like outer part. Okay? So it will resemble the real counterpart. Found on the opposite side of the film, say you are wearing a left side earring, on the X-ray it will appear on the right side. And it will appear larger. Ring will be only this much, but when you are seeing it, it will be huge. Okay? And it will be, suppose it is at this level, on your OPG it will be at this level. It will be higher than the counterpart. Okay? During positioning of OPG. Reverse smile. Okay? The frequency, the other one. The head tip down during positioning, yes, exaggerated smile. Head tip up, then you have a reverse smile. You can see for yourself actually. You tip down and smile. Your smile is your exaggerated smile. You tip up and see, your smile becomes reverse. And when do you have blurring? Motion artifact. Patient moves during exposure, you have a blurring. And ghost image is one artifact. When do you have a black image on one half of your OPG? When the OPG is going around you, around the patient, okay, if the shoulders are going to be broad, the movement will not happen synchronously. It will get stopped by your shoulder. So from that time onwards, your X-ray will appear black. So half X-ray will be correct, but remaining half will become black. Okay. The frequency of human hearing ranges between. See? Yes. And 1 to 20 megahertz is for ultrasound. The X-ray tube of a CT machine has a rotary anode with a large focal spot where the heat units off. We already spoke about heat units on intraoral machine. This is heat units for CT. So that is B, 1 to 4 mega heat units. The table travel per X-ray tube rotation or image thickness is called as Hounsfield units, pitch, okay. CT number and Hounsfield units means the same. It is the amount of attenuation of the X-ray beam on a particular thickness of tissue which is being assigned a value which is CT number, okay, and it is being named as Hounsfield unit after the person who has found this, Godfrey Hounsfield, okay. Say suppose Computer does not recognize this as no's, this as yes. It knows it as 1, 1, 1, 2, 2, 2. It's a binary system. So that is your CT number. Voxel is the thickness of tissue through which your X-ray beam has attenuated. It includes the outside portion that you are seeing and the thickness of tissue that you are penetrating. Okay. The outside portion which you are only seeing is called as a pixel. It will have only the height and the width. It will not have the thickness. Whereas a voxel has a height, width and the thickness. Okay. And the attenuation of the entire voxel is only your Hounsfield unit. In a CBCT during rotation, many exposures are made at fixed intervals. Provide a single projection image is called as, during CBCT is also something like OPG, it is going to rotate around the patient. So it causes various exposures at definitive intervals. So each image which is obtained during this procedure is called as. Have you read this chapter on CBCT? No? It is there only in the 6th edition. That is a separate chapter. It's called as basis images. Okay. The single image that you get is a basis image, like a section in your CT. Okay. All that put together to give one whole image is called as your projection data. And whatever is happening, basically all these are softwares, and it will work on algorithms and flowcharts. The algorithm which this CBCT uses is called as back filtered projection. That is the algorithm or your mathematical calculation which is being used by the system to produce a useful image. Okay. The contrast agent used in MRI is. Why do you use a contrast agent? To enhance the appearance, whatever appearance it is to enhance the appearance from the tissues surrounding it. It will improve your appearance from the surrounding structures. You will be able to see a lesion even without a contrast agent, but along with the contrast agent, you will have more of enhancement. So the answer is gadolinium. Okay. Urographin is used for CT. Trivideo is also used for CT, but generally for pediatric patients. And hydro-opaque is a material which is used for xylography. Okay. What is xylography? Injection of a contrast medium into your salivary gland ductal opening, and that will get filled in your salivary gland, and you will take a normal extraoral radiography to see this tree or the normal salivary gland structure. You will see the anatomy of a salivary gland by the process of xylography. What are the conditions in which xylography is contraindicated? Acute infection, patients on thyroid medication, patients having allergy to iodine. Basically, these contrast agents are having iodine. So, patients having allergy to iodine is also contraindicated. What are the types of contrast agents you know of? Water-based and fat-based. Okay, fat-soluble and water-soluble. The Larmor equation is given by the formula. Where does this Larmor equation come under? MRI. I think you've skipped the chapter on advanced imaging itself. Okay. See, basically our human body is composed of water molecules. 75% of water molecules, right? And these water molecules come by the formula of H2O, which means you have hydrogen atoms also lying in your body. When you are normal, like you're sitting now, your hydrogen atoms will be randomly oriented in your body. And when you're placing that person into an MRI machine is something which has magnetic power of almost 1.5 to 2.5 Tesla. Tesla is the unit of magnetic power. It's like kilogram, gram, madri. How much of power a magnet has is defined by Tesla. So that much of magnetic power will cause the orientation of your hydrogen atoms into a aligned, very formatted way in your body. It will align either in a spin up format or a spin down format. This means it will be either in the north pole direction or in the south pole direction. Basically it acts like a magnet. Okay. Now you are switching on the MRI machine. Until then the MRI will be working. That is, your magnets will be working, but you will not have a pulse going on inside the patient. Magnet, you can never ever switch off a magnet in an MRI machine. You don't have a switch off or a switch on button in an MRI machine. All that you are doing is you are giving an extra radio frequency pulse. You can never switch off an MRI machine. Okay. So I am placing the patient inside the gantry, and the hydrogen atoms are getting oriented as either north pole or the south pole according to the external magnetic field. The upper pole you call it as spin up. If it goes down, it is called as a spin down. Okay. Now what will happen is I am giving an external radio frequency pulse. When this happens, it will get further aligned, and your upper will, like your spin up, will start cancelling the spin down. So say suppose there are 50 spin ups and like 40 spin downs. The 40 will get cancelled down. You have one excess. That excess of 10 spin up is called as your net spin echo. Okay. This is your net magnetization. Net magnetization. This is the one which is going to give you a useful image. Now you switch off the RF pulse, like how a photon exits out through an electron. We tell that, right? Where once it displaces an atom, this electron displaces in an atom, we say a photon exits through the electron. Correct? So similarly, when I am switching off the radio frequency pulse, you will have a photon which comes out from the patient, and that is being detected by your detectors in your gantry. Your source and the detector are there inside the same gantry. So through the detector you are getting a useful image. And out of this you have something called as T1 weighted image and T2 weighted image. T1 weighted image is for looking at the anatomy of the patient, and T2 weighted image is looking for the pathology of the patient. Any enhancement you will be able to see in a T2 weighted image. I think last class I told you about there is only one thing which you can see only in an MRI but not in any other exposures. Soft tissue is one. Then I can see soft tissue in UST also. Yes? Yeah. So there is one feature which I can see only in MRI but nothing other than that. I told you last class in salivary gland chapter. Perineural invasion. Perineural invasion is a finding which you can see only in MRI and no other radiographic projections. And you have something called as MR xylography. Apart from your regular xylography, you have something called as MR xylography. You do not inject any kind of contrast medium. Instead, you will stimulate patient saliva by giving paraffin. So salivary flow itself is increased, and that is being detected as a MRI xylography. The contrast medium used is patient's own saliva. So basically, it is non-ionizing, okay, and it is non-invasive technique, and it is a safe technique. MR xylography is the safest xylographic technique. So the Larmor equation, F stands for Larmor frequency or your precessional frequency. That is, I told you, you have the hydrogen atoms either in the spin-up format or the spin-down format. But apart from being in that format, it will also precise about a central point. That precession is called as your Larmor frequency, the rate at which your hydrogen atoms is spinning. It spins like a top. The hydrogen atom basically will be spinning, not just up or down, it will also spin within itself. Like Earth is not only spinning around itself, but it is also spinning the sun. So the same principle, the hydrogen atom is not only in the spin up or spin down direction, but it is also spinning around itself. So that spinning is called as a precessional frequency or Larmor frequency. And that frequency depends upon the formula YBO. Y is your gyromagnetic ratio unit of magnetic field strength. The amount of magnetic field strength that you are applying externally, that is your Y. And BO is the strength of the external magnetic field. That is the ratio and that is the strength. Okay? And medically we are using a magnet. This much of magnetic power can actually pull a lorry inside the machine. That is why they are having a closed room. And if you see when you're walking inside your MRI room, they will have a metal detector to be checking yourself. Even your earring can pull you and stick to the MRI machine and cause death. We cannot switch off an MRI machine. Okay. I think a couple of accidents have already happened. MRI is contraindicated in. Indicated, of course, for soft tissue lesions. It is contraindicated in A and B. Okay? Yeah. Claustrophobics. What is claustrophobia? Yes, fear of closed space. And patients with surgical clips and cardiac pacemakers, again metallic stuff, so it is contraindicated. So say suppose patient is having amalgam restoration or ceramic crowns or metal crowns. What do you do then? You can go moving it around. Mask with something. No. No. Does it have iron? Your ceramic crowns. See, magnet has a pulling capacity to iron, not your stainless steel or not your other metals. So it is not, have you seen magnets attracting stainless steel? Chromium metals? No? Yeah. So your amalgam filling is allowed, your metallic crowns are allowed, but the problem is you will have streak artifacts. Normally when you are looking at a metal on a radiograph, it will appear radio opaque, correct? But in MRI, it will have streak artifacts like, like static electricity, you will have radio opaque lines all around, which means it is going to mask your diagnostic efficiency. Okay? Right. Piezoelectric crystal in ultrasound is used is D. Yeah. Lead zirconate and titanate. What is the principle behind using an ultrasound? Sound waves. Okay. So the sound waves that you're using in ultrasound is much more than what you're actually able to hear. So your ultrasound sounds you will not be able to hear. Okay. So the sounds are passing through your tissues and it has some kind of an acoustic impedance, and you will at each tissue level the sound passes through, it will show some kind of a response. You will have a penetration and a reflection. When that reflection hits back your transducer, you will get as a useful image on your computer. The transducer that you are using in ultrasound machine, that is the machine, you have seen the stick lighting which you are applying on the skin. It serves both as a sender and a receiver. It is sending sound signals and it is receiving the pulses also from the tissues, and that is being visible on the computer. And you have something called as color Doppler. Okay, if you are going to image some kind of vascular tissues, hemangioma, it is going to show color like red and blue based on the amount of flow that is being happening inside the tissues. Alright. Which of the following is a real-time imaging? USG, what's the meaning of real-time imaging? Means whatever you are seeing is actually happening inside also. It is a real-time imaging. Apart from it's a fourth dimension, height, weight, all that. Apart from that, this is a fourth dimension that you are seeing. Whatever you are seeing on the screen is actually currently happening in the tissues within. Okay? What is fusion imaging? Okay. Some radiographs are anatomy, like your CT, your MRI, they all image your anatomy. Some images are functional, like for example your nuclear imaging, it will assess the function of your organ. It will not assess your anatomy at all. That is a problem with your functional imaging. You cannot see the normal anatomical structure of a salivary gland. You cannot see the bones. You cannot see the tissues around. But all you will see is the function of the gland. If the gland is having some inflammation, it will appear like red spots. If the gland is having some kind of a neoplasm, it will appear like blue spots. So basically, it is going to assess the function of your tissues. So, an imaging technique which will combine both your anatomy and your function is called as fusion imaging. For example, PET-CT. Your positron emission tomography is a functional imaging, and your computer tomography is an anatomical imaging. When you are combining these both, it's called as a fusion imaging. Okay? Sorry? Positron emission tomography, first they will take a CT. They will assess the anatomy. Along with that, then they will place the patient in a CT machine. Some machines will have a combination of both, some will have to be done separately. When you're taking CT, you are getting the anatomy of the organ, say suppose salivary gland. When you're placing the same patient in a PET scanner, you're getting the function of the salivary gland. You're combining these two images using software, you will have a PET CT scanner. Okay, you will have both the anatomy and the function of the organ assessed. So, which is the following is a functional imaging PET, okay. Among this list, which of the following is non-ionizing imaging technique? MRI? Only MRI? UST and MRI, okay. CT? No, that is anatomy. You are seeing glands, you are seeing the vessels, yes? Yeah, answer is PET, yeah, okay. The description of UST images is given as C, yes, echogenicity. So hyperdense and hypodense is given by CT. Okay, radio opaque, radiolucent, that is mentioned in regular radiographs and in CBCT. Okay, and homogeneous or heterogeneous enhancements is given in MRI. Which of the following are radioisotopes used in nuclear medicine? Nuclear medicine is a functional imaging technique. A and B, yeah. Thulium is seen in, where do we use thulium? Niobium, thulium. They are the rare earth materials which you are using in your intensifying screens. Okay. The appearance of a silolith in UST is described as whatever echogenicity they are talking about, they are comparing with the surrounding normal structures. So if it is going to be hypo, means from the surrounding it is of less enhancement. If you are saying hyper, from the surrounding normal structure it is more enhancement. If you are saying iso, from the surrounding structure it is the same enhancement. You do not see a difference between the pathology and the normal tissue. So the description for a silolith is D. Okay, silolith is going to be hyper and it is having a post-acoustic shadowing, meaning you are sending sound waves but it is getting blocked by a silolith. So it is like a shadow that is cast behind. Say you are standing in front of the sun, you will appear very bright, but when you are blocking the sunlight, you are having a shadow behind you. So that is exactly the example that you can give for this. The agent used in positron emission tomography is the PET scanner. It uses an agent, that is, you use a contrast agent to give it to the patient IV, and then only you place the patient in the PET scanner. That is 18F fluoro 2-deoxyglucose. The others are all not answers at all. Okay, it doesn't fall for the other agents also. 18F fluoro 2-deoxyglucose. So you will actually inject this IV to the patient and then you will place them in a room. They will have it for 45 minutes before your exposure. The agent will spread across the entire patient and then you are placing the patient inside the PET scanner. Once you begin the exposure, you will have annihilation radiation. You will have electrons flowing from the patient's body and it will be detected onto the PET scanner. It will be a ring scanner, just like the CT MRI machine. You have a ring of detectors. The electrons emerging from the patient will hit the detectors in the opposing points and that will be connected to a system, and through the system you are seeing a useful image, a functional imaging technique. If only that particular area you have a pathology, that area will have a high contrast and that area alone will appear on the computer. Okay. Which of the following are radiographic appearances of osteomyelitis? All of the above? Onion skin appearance occurs where? Sorry? Where does it occur in the bone? Gary's osteomyelitis? Yes. It occurs in a regular osteomyelitis also, but it will occur as a peripheral osteal reaction. You have the cortex, okay? You will have bone deposition in laminated patterns. It can occur even in acute suppurative osteomyelitis as a effect of surrounding structures. When you are telling a radiographic appearance, you can divide it into the periphery, internal lesion, and the effect on surrounding structures. So these three, based on which the radiographic appearances can differ for the same case. Moth-eaten appearance is just you have radiolucencies within the bone, alright, in the medullary portion. And cotton wool appearance appears in which type of osteomyelitis? Chronic generalized sclerosing osteomyelitis. In chronic focal sclerosing osteomyelitis, you have only in one area, that can be a moth-eaten appearance. In acute suppurative osteomyelitis, you have moth-eaten appearance and onion skin appearance. In Gary's osteomyelitis, you have only onion skin appearance. Alright? Floating tooth appearance is seen in D? B or D? D. Squamous cell carcinoma, eosinophilic granuloma, Papillon-Lefevre syndrome, aggressive periodontitis, all these you will have floating teeth appearance. Copper beaten appearance is a feature of hypophosphatasia, all of the above. Clausen syndrome, Apert syndrome, hypophosphatasia. What is copper beaten appearance? How will it look like? You just take a sheet of copper and beat it. You will have indentations, ups and downs. So that is a copper beaten appearance which is seen on a skull radiograph. Areas of delayed or hypoossified areas, you will have this. Ice cream scoop appearance is a feature of C. Langhans cells histiocytosis. Where is the I'll tell you, I'll ask you later then. What is osteopetrosis? Marble bone disease. You will have excessive bone deposition. You will have loss of periodontal ligament space. It will be obliterated. Osteoma cutis is soft tissue osteomas. That is osteoma cutis. You have a snowflake appearance in osteoma cutis. Meningioma, benign neoplasm of your meninges. Radicular cyst expansion clinically shows which of the following effect? A. Eggshell crackling effect. You will have a cortical plate expansion. When you press it, it will be like egg cracking. When you try to crack an egg, that kind of an effect will be. What peripheral eggshell effect? Sorry? Okay, where is your peripheral eggshell effect seen in? Mandible? Where? Okay. X? No. It is seen on the mesial root of your first mandibular molar. Okay. If you see, it will be like bent. It has a mesial angulation, right? All the lamina dura is only single, but your mandibular first molar will have a double lamina dura, and that is because of the peripheral eggshell effect. If you see an egg, you will have the top portion and the middle portion. The middle portion has only, like your X-ray will pass tangentially as a straight line. When it is passing on the top portion, the two sides of the egg is so close to each other, so this portion and the opposite portion will be seen as a double lamina dura. So if you see only on that mandibular first molar region, because of the anatomy as how it is being, the curvature of your root, it is appearing as a two lamina duras. Okay. Peripheral eggshell effect is seen in the lamina dura, double lamina dura. Mandibular first molar mesial root. Radiographically, step ladder pattern is a feature of A and B? Yes. What is the radiographic appearance of hyperparathyroidism? Salt and pepper appearance, okay, and you will have plasmoblastic tumor, alright. Odontogenic tumor are as follows except. This is easy. Something you know the answer is definitely not there. A. Salt and pepper appearance. New moon, cotton wool, fluffy cloud are all the appearances of CCOT. They are the patterns of calcification occurring in a CCOT. Washer shaped appearance is a feature of. You can give it as washer shaped or donut shaped. So either of this is an appearance of. One of a normal anatomy also has a donut appearance. Which normal anatomy gives a donut appearance? Sorry? Donut appearance வந்து ஒரு normal anatomy கூட சொல்லுவாங்க. What is the foramen in your symphysis? Yes, your lingual foramen surrounded by the genial tubercles gives a donut appearance. Okay. Washer shaped appearance is a feature of osteoma cutis. Enlarged pulp chamber, which is taurodontism, is a feature of a or absence of one or few teeth is called as. Then what is oligodontia? Missing of teeth more than 6 is considered as oligodontia. Anodontia is complete absence of teeth. Where do you have complete absence of teeth? Ectodermal dysplasia? Many times I have anodontia. Macrodontia can occur due to gigantism? Okay. All of the above. Hemangioma, actually the blood supply to the blood is so much during the development stage that the tooth size increases. And hemi hypertrophy, that half of the face itself will be enlarged than the other half of the face. Gigantism is like not just one tooth, entire teeth will be enlarged. Flame shape or thistle tube shape pulp chamber is characteristic of regional odontodysplasia, dentin dysplasia. Regional odontodysplasia is your ghost teeth. You will not have roots at all. It will be like your tooth is just hanging in air. Calcification that forms in degenerating, diseased and dead tissue despite the normal serum calcium and phosphate levels. Dystrophic? Okay. Don't keep changing. Normal serum calcium. And that will not, see, idiopathic occurs without any reason. Dystrophic is around the dead and degenerating tissues. Metastatic, you will have increased serum calcium levels. There is no such thing called dysplastic calcium. I didn't have an option to write. Varying degree of radiopacity with cauliflower-like outline is a feature of. This is a chapter on soft tissue calcification in your 5th edition of White Arrow. What is androlith? In calcification in the maxillary antrum. Xylolith, you know. Rhinolith? Nose. Calcification of the nose. So a cauliflower outline of is a calcification node. Okay? Radiographic pipe stem or tram track appearance of the periphery is seen in Monkeyberg's medial calcinosis, that is also calcification of vessels. Phlebolith, you will not have a tram-like appearance, that is, you can either give the answer as hemangioma, okay, in hemangioma or Sturge-Weber syndrome, or you can give for Monkeyberg's medial calcinosis. All these are similar things, alright. Phlebolith is only going to appear as a uniform radio-opaque structure, that's all, along the line of a vessel. What's the cysticercosis? Tinea solium infection, okay. The larva gets implanted into your intestines and then you will have calcification occurring anywhere in the body, commonly occurring in the brain. Calcified atherosclerotic plaque, a plaque formation occur in the blood vessels and that later gets calcified. So that is going to be what type of calcification? A calcification around the dead and degenerating tissue, dystrophic calcification. Radiographically, the grain of wheat appearance in the periphery is a feature of. You have grain of wheat appearance, grain of rice appearance, cauliflower appearance. All these are there in the chapter of soft tissue calcifications in 5th edition of White and Farrow. Any idea? Grain of wheat appearance? Laryngeal cartilage calcification. This calcification can be seen perhaps in your CBCT. You can see the larynx itself on a CBCT. CBCT is more like it's half a CT. Radiographically, washer-shaped or donut-shaped appearance of the periphery is seen in osteoma cutis. One more appearance I gave you. I just spoke about one more appearance of osteoma cutis. Radiographically, OPG appearance of an enlarged coronoid process is you have hyperplasia, hypoplasia of condyle. You have hyperplasia, hypoplasia of your coronoid process. So your hyperplasia of coronoid process appearance is called as a what? Sorry, didn't get you. A, that is seen in juvenile arthrosis or Boring's disease. B-O-E-R-I-N-G-S, Boring's arthrosis. Drumstick appearance. Where do you have a bird face appearance? Peary-Rombin syndrome, yes. Bilateral ankylosis of your TMJ, you will have a bird face appearance. Orange peel appearance is seen in fibrous dysplasia. The growing cyst may cause a pressure on the neurovascular bundle, giving rise to paresthesia or numbness and tingling sensation. This I just wanted to give you the answer because I already spoke about your inferior alveolar nerve paresthesia and their causes. And when that happens in case of a cyst, it is called as a Vincent sign. I skipped the signs in oral medicine. I skipped one sign, that is this one. Okay. Vincent sign. The cyst is growing and it is spreading to the inferior alveolar nerve. It is causing a pressure which is leading to paresthesia. This is called as Vincent sign. The sagittal view of a lateral aspect of condyle can be best viewed by. What are all the TMJ projections you know of? Transcranial, transpharyngeal, transorbital. Okay? We will keep these three. Apart from this, we have various other projections. So, of this, which will give you the sagittal view? The lateral aspect, your transcranial view. Okay? The transorbital view gives anteroposterior view, and transpharyngeal will give the medial view. Still's disease is the other name for juvenile chronic arthritis. Still's disease is the other name for juvenile chronic arthritis. I told you the difference between rheumatoid arthritis and osteoarthritis last class. It is there in the name itself. The arthritis affecting the bone first and then the synovial membrane is osteoarthritis. The arthritis causing a primarily synovial membrane inflammation first, followed by the bone erosion is called as rheumatoid arthritis. Remember the difference last time? Carrot-shaped condyle is a feature of all this is there in White and Farrow. What is ankylosis? Fusion of your condyle of the mandible and your glenoid fossa. It can be either a fibrous fusion or a bony fusion. It can be a true ankylosis or a false ankylosis. It can be either unilateral or it can be bilateral. Okay. What is neonatal fractures? The fracture happening during childbirth. You try to do a forceps extract, forceps delivery, that time it happens. Okay. What is dislocation? Yeah, so the condyle slips from the glenoid fossa beyond the articular eminence to dislocation. What is subluxation? It goes beyond the articular eminence, but it is able to have a self-reduction back to your glenoid fossa. What is adherence and adhesion? It is a form of your ankylosis, okay, but it is not that it is permanently stuck. It is that your lubrication is lost, because of which constantly it is getting stuck to your glenoid fossa. But it is coming off, on, but at times it can permanently adhere, and then it can become an ankylosis, okay. So the carrot-shaped condyle is a feature of neonatal fractures, okay. Thin radiolucent area that closely follows the entire outline of the implant is suggestive of. You take a pre-op radiograph, you take a post-op radiograph, you take an intra-op radiograph. That is during the implant placement. In a post-op radiograph, if you see a thin line, radiolucent line, closely along the entire implant, that is called as, first it has a name, and that name, and second it has a reason. So what is the name? What is the reason? D. Okay. And the name is peri-implantitis. 12 o'clock you wanted a break, no? Over class.